Hi, folks. This is Abnormal Psychology, and today we're talking about trichotillomania, which is compulsive hair pulling. Yeah, this is an interesting one. The DSM-5 talks about it in this way in terms of the diagnostic criteria as being recurrent pulling of one's hair that results in noticeable hair loss from areas that should have hair. They repeated in their attempts to stop doing this without success. So there's a compulsive element. This causes distress or impairment, depending on the what we're talking about, which realm we're talking about. Social, occupational, relational kind of thing. So this is probably more common than we know. So the most common areas for pulling hair are the scalp, usually at the back, neck, perhaps, eyebrows, eyelashes, but not limited to that. It can be pubic hair, axillary hair, hair from other animals, fibers from pillows, and so on. And there may be consumption of those items, hair, which then can lead to a digestive problem where the hair backs up and creates what's known as a bezoar, Bezoar, and that is a mat of hair or other indigestible substances that interrupts the process of digestion. So what they get is mounting anxiety, stressful events. They get an itching-like feeling, and when they're alone, they will have so much tension that they pull the hair as a way to reduce the tension. And when they do pull hair, it feels better for a very short period of time, a sense of pleasure or gratification. They may be someone who twirls their hair, or look at the hair root after they pull it, the strand of hair between their teeth as if they were somehow relishing in its taste or its texture. They may be nail biters, scratching, gnawing. They may also be skin picking folks. Excoriation disorder is a condition that accompanies this. Yeah. So gender differences, it's 10 to 1 female over male. Prevalence is maybe 1 to 2%. We don't really know. Onset is early adolescence, and the course is chronic with wax and wane episodes. That's clear. Comorbidity is depression, this excoriation disorder that I talked about, and a clinical observation would be social anxiety disorder. How do we treat this? Well, cognitive behavior therapy, identifying and avoiding triggers, countering the maladaptive thoughts and beliefs, which is the cognitive portion of cognitive behavior therapy, teaching coping strategies, teaching people relaxation skills, SSRIs, maybe even naltrexone, which blocks the pleasurable effects of opioids. And in big cities, there may be 12-step programs, but not in smaller places. That's about all I have for trichotillomania. Enjoy.